This is part 5 of our module, Drugs Acting on the Cardiovascular System, specifically Antianginal Agents, which is chapter 46 of our reference book. Antianginal agents are used to help restore the appropriate supply and demand ratio in oxygen delivery to the myocardium. An imbalance in this ratio, manifested by pain, is most commonly due to coronary artery disease or CAD. CAD has for many years been the leading cause of death in United States and most Western nations. Despite great strides in understanding the contributing causes of this disease and ways to prevent it, CAD claims more lives than any other disease. The drugs discussed in this chapter are used to prevent myocardial cell death when the coronary vessels are already seriously damaged and are having trouble maintaining the blood flow to the heart muscle. For our learning objectives, upon completion of this chapter, future nurses will be able to describe coronary artery disease, including identified risk factors and clinical presentation, describe the therapeutic actions, indications, pharmacokinetics, contraindications and cautions, most common adverse reactions and important drug-to-drug interactions associated with the nitrates, beta blockers, and calcium channel blockers used to treat angina, discuss the use of anti-anginal agents across the lifespan, compare and contrast the prototype drugs nitroglycerin, metoprolol, and diltiazem with other agents used to treat angina, outline the nursing considerations, including important teaching points for patients receiving drugs used to treat angina. The coronary artery disease or CAD. So this is caused by plaque buildup in the wall of arteries that supply blood to the heart, the one called coronary arteries. In CAD, the lumens of the blood vessels become narrowed so that the blood is no longer able to flow freely to the muscle cells. Narrowing of vessels caused by atherosclerosis or fat buildup, but it could also be caused by buildup of cholesterol and other substances in and on the artery walls. The buildup is called plaque. The plaque can cause arteries to narrow, blocking the blood flow. The plaque can also burst, leading to a blood clot as shown in the picture. So the person with atherosclerosis has a classic supply and demand problem of oxygen. So the heart may function without a problem until the problem increases, like when there is increase in activity or other stresses that will place a demand on the heart so that it need to beat faster or harder. Normally, the heart would stimulate the vessels to deliver more blood when this occurs, but the narrowed vessels are not able to respond and cannot supply the blood needed by the working heart. So heart muscles becomes hypoxic, manifested as pain, or angina pectoris, which literally means suffocation of the chest. We now move on to angina, which is pain as body's response to a lack of oxygen in the heart muscle. Pain is felt whenever substance P reacts with pain receptor. So actually, the heart muscle does not have any pain fibers. It's only by the time that a substance called factor P is released from ischemic myocardial cells that pain is felt. So for that, we have stable or chronic angina wherein no damage to the heart muscle. Basic reflexes surrounding pain restore blood flow when activity is stopped. So the basic response to this type of pain is to stop whatever one is doing and to wait for the pain to go away. In cases of minor limitations to the blood flow through vessels, stopping activity may bring the supply and demand of blood back into balance. This condition can severely limit a person's activities and quality of life. Unstable or pre-infarction angina. So here, the heart may experience episodes of ischemia even when patient is at rest. So this happens if the narrowing of the coronary arteries becomes more pronounced. Although no damage to heart muscle occurs, the person is at increased risk of a complete blockage of blood supply to the heart muscles if the heart needs to work harder or the oxygen demand increases. The pinched metal angina is caused by spasm of blood vessels and not just by vessel narrowing, with angina at rest, often at same time each day, and usually with an associated ECG pattern change. The acute myocardial infarction. So this is a heart attack, a myocardial necrosis or ischemia that results from occluded coronary vessel or artery. So excruciating pain, nausea, and severe sympathetic stress reaction may be noted. So this is a serious danger of an MI is that arrhythmias can develop in nearby tissue that is ischemic and very irritable. Most of the deaths caused by MI occur as a result of fatal arrhythmias. So if heart muscle has a chance to heal within 6 to 10 weeks, scar tissue will form in the necrotic area and muscle will compensate for the injury. If the area of damaged muscle is very large, muscle may not be able to compensate for the loss, and heart failure and even cardiogenic shock may occur. So these conditions can be fatal or can leave a person severely limited by the weakened heart muscle. We move on into antianginal agents and nitrates. Antianginal agents are used to help restore appropriate supply and demand ratio in oxygen delivery to myocardium when rest is not enough. Improved blood delivery to heart could be in one of two ways. First, by dilating blood vessels, like increasing the supply of oxygen. Second is by decreasing the work of the heart, like decreasing the demand for oxygen. The demand of oxygen by the heart muscle is influenced by the heart rate, preload, afterload, and stretch of ventricle. Okay, for the heart rate, a faster heart rate requires more energy. And for preload, the more blood returned to the heart, the more pumping will be done to empty it, which requires more oxygen. For the afterload, the more pressure the heart has to pump against, the more energy is required. And for the stretch of ventricle, the farther apart the actin and myosin fibers, the more energy is used as they react and slide or contract. Okay, nitrates act directly on smooth muscle to cause relaxation and to depress muscle tone. Because the action of nitrates is direct, these drugs do not influence any nerve or other activity, and their response is usually quiet fast. Nitrates include amyl nitrate, isosorbide dinitrate, isosorbide mononitrate, and nitroglycerin, and others. So we have here anti-anginal agents. So I will leave it up to you to look closer when you grab a copy of your PLP. So we have here beta blockers, calcium channel blockers, and the piperazine acetamide. And then our drugs across the lifespan. And then here are therapeutic actions, indications, and pharmacokinetics for the different agents discussed in this topic. So I will leave this also to you to look closer when you got or grab a copy of your PLP. So we have here nitrates. Okay, then we also have safe medication administration for drugs included in this chapter, and then prototype summary of some of the drugs, and then we also have beta adrenergic, which was already discussed in chapter 31, and then the calcium channel blockers, which include amlodipine, diltiazem, nicardipine, nifedipine, and verapamil. And then the piperazine acetamide agents, which is with its therapeutic actions, indications, and etc. And that is the end for this set of slides. Thank you for your attention.